Hi, good evening, everyone, and welcome to the next episode of Nearly with Nadira, Cracking the Mac Code. And truly, today I'm really excited because I'm joined by, as you can see, so many of these key opinion leaders who are true masters of mitral annular calcification. And I think the next hour you'll see exciting cases, interesting cases, truly crazy MAC cases, and how to treat them with transcatheter options, as there's so much from TCT with all the two transcatheter mitral valve replacement technology. And truly, this is a field that is, evolving so rapidly. And so truly, I'm going to introduce you to with my moderators. Really, it's a privilege to moderate this with Dr. Kaneko, who I know really well, a true friend. Thank you very much. And also with Dr. Benjamin Sun. For those who don't know him, he is a world-renowned surgeon who I have the pleasure of working with him in Minneapolis Heart Institute, and has been a true instrumental, key in the Tendyne trial, as he did all the cases in Minneapolis Heart Institute, and until I joined them and did the last few cases before finishing enrollment. And also, I call her the queen of Mac, who is Dr. Mayra Guerrero. Thank you so much for joining us. And we have our three exciting presenters. First, with Dr. Jason Rogers, who will be presenting us a case on Tendyne. And the second one with Dr. Guy Attizzani on a very interesting MAC cases with the Alta valve. And the third, Dr. Gennaro Giustino, who will be joining us as he's finishing up a late case on the matrix procedure, which he published. And I'm truly excited to hear that. And without further ado, I'm going to hand it over to Dr. Rogers, who will be presenting us his first case.
Great. Thank you, Nadira. I am going to share my presentation and get this going. All right. Can you see that all right?
Yes.
Yes.
Okay, great.
Yeah.
So we're going to start cracking the MAC code with Tendyne. And I don't know how far we'll crack this egg tonight. It's a pretty big egg. It's got a thick shell. But I think we've made some significant dents in this field. So my disclosures are that I was one of the co-PIs for the Summit trial, which studied the Tendyne, and I work closely with many of the people on this call. So the notable thing about Tendyne is that this is the first FDA-approved transcatheter mitral valve replacement system dedicated. And this was just approved in August of this year, specifically for patients with MAC, either MR or MS or mixed MR and MS. And you can see the design. There's an outer frame that's shaped like a D to conform to the annulus. And then the inner frame is circular like any bioprosthetic valve would be. It has a bioprosthetic leaflet, has 5 sizes. And I think what's unique about this valve is the anchoring mechanism. There are no barbs or frictional elements. It's purely anchored by a tether, which is connected to a pad at the apex of the heart. And the device is delivered transapically, and this pad assists in hemostasis, and it really pulls the valve into position. Because there is a tether, you could actually retrieve and reposition the valve after full deployment. So this Summit MAC study was just published in JACC, and it was presented at TCT as a single-arm study, non-randomized, looking just at MAC patients. The primary endpoint being all-cause mortality and heart failure hospitalization freedom at 12 months. And just to briefly touch on what type of patients you might be looking for Tendyne, there are patients with either mitral regurgitation or isolated mitral stenosis or mixed moderate MR and MS. EF greater than 25, LV can't be too big. We don't want patients with right heart failure, severe TR, or pulmonary hypertension. So these were the patients that were selected for the trial. We'll talk about this. I mean, a lot of the patients were excluded. So we have about a 20-25% screen pass rate. And it'll be interesting the other technologies, what their screen pass. But I think that's still a limitation of Mac devices, is that there's a large screen fail rate due to LVOT or annular size. But we were able to enroll 103 patients. These are some pictures of the kind of representative spectrum of Mac, from lesser Mac to more Mac. The average Mac volume was 5,679 in this series, so pretty significant Mac. So here's a case that we enrolled in the trial. This is a 7-year-old woman. We know Mac is more common in women than men. Older woman, some comorbidities, but preserved ejection fraction, which most of these patients have. She had severe MR and some mitral stenosis. You see the other comorbidities with radiation therapy, history of mastectomy. We do encourage, like a complete workup, including right heart catheterization, coronary angiography on any MAC patient, just like you would be sending them for surgery. And we want to make sure they're on adequate medical therapy, which this patient is. Also, very importantly, all of these valves, that patients have to be able to tolerate anticoagulation for at least 6 months. So these are kind of the key steps of the procedure that we'll go through. And, it really starts with a TEE. Transthoracic is okay, but we really need a T to look at the annular landing zone and to confirm the severity of disease. So this patient has severe MR. The baseline on FOS, you see the distribution of calcium. We'll see this also on the CT. But importantly, the T is necessary because this is how we guide the procedure, and we have to have good views of the annulus, because this is how the valve seats. If you can't see the whole annulus, you can't really confirm seating. So I think this is important for any technology. You have to be able to see the whole valve. The LVOT or neo-LVOT measurement that was used in the trial was fairly conservative, a little larger at 250 millimeters squared. Many operators would use 200. So we were pretty conservative and wanted to make sure we didn't have any LVOT obstruction. In looking at the MAC distribution, we have the outer frame, which absorbs a lot of the MAC irregularities, but importantly, we don't want any calcium intruding on the inner frame. And in this example, you can see there's a little spicule of calcium around about 2 o'clock on the right image that's encroaching on the inner frame. And for this reason, in the trial, we used pre-dilatation. We used a balloon, and a balloon was used in about 70% of patients in the trial, mostly because of concern of an inner frame interaction. So now this may be like TAVR, where we pre-dilated every valve, initially in the experience, and then we learned later on we didn't have to do that. So I think this is something where the Tendyne procedure may evolve, that we don't really have to pre-dilate with every valve, but it's pretty easy to do. We already have transapical access, and in most cases, we're using a 28 millimeter true balloon. The other nuance to this procedure is the apical access, and this is really a surgical procedure for access. The company will give you a projected optimal transapical access site with the green dot versus the red dot, which is the true anatomic apex. So we really want the transapical access to pull the valve a little bit away from the LVOT. And during the procedure, the surgeon would select the spot by gently pressing on the apex of the heart with the finger. And we can kind of pick the spot, and you can see on these 4-chamber or apical views that there's an indentation at the apex on TE, and that's where we would aim to go. Once that spot is picked, then we use a combination, like most procedures, of fluoro and echo. Here's the wire going in. Initially, usually goes out the aortic valve. And then, we confirm that it's within the mitral annulus by flossing. I didn't show that. We use a balloon tip catheter to floss and make sure that we're not interacting with any cords. But then we would then pre-dilate the valve through the apex with a true balloon. And you can see it going up and down here. So this is kind of an example of how on TEE, I think this is nice imaging, Nadira, on the left. We can see at 2 o'clock, pretty immobile kind of A3 segment of the anterior leaflet. And then on the right, it's moving a little bit more. So we have mobilized the calcium. So that's always nice to see. And then, really, I mean, this is like a 15-minute procedure at this point. You basically just deploy the valve and the tether. We want to make sure that we deploy the valve within the MAC because the calcium interacts with the frame and you can't really just pull it down. So it has to deploy at the right level. So we spend some time on imaging, making sure the sheath is centered in the valve, and we advance the valve to the tip, and then we flower the valve. We deploy the valve, we push it out very slowly, step by step, and make sure that everything is seated and appropriately against the annulus. So that's kind of what that's showing here. And then, once that's in, you see what that looks like here. We want the atrial flanges to be flush. We can check for any LVOT gradient at this point. If there's a gradient, we can recapture the valve. It's not emergency at this point. But if everything looks good, this is what it looks like. And then the final appearance with the apical pad is shown here on the left. You can see a little bit of the fluoro outline of the pad. And of course, the significant amount of MAC on the fluoroscopy on the left. So this patient did quite well. I mean, they went home in 4 days, which I say would be very, very soon. Most of these patients are around probably more like 5 to 7 days. They tend to be frail, older, and it is real surgery. It's a thoracotomy. So, this is a best case scenario I'm presenting here. There's 5 sizes. We emphasize some of the procedural aspects. Just to briefly touch on the Summit trial outcomes, which were presented here recently in the 103 patients. I think one thing about this procedure is that it is highly reproducible and predictable. So procedural success here was 98%, very, very high. Technical success, 94%. In a few cases, the valve had to be retrieved or repositioned. There were, a few cases where there had to be surgery performed, usually for some apical bleeding. But you can see the use of cardiopulmonary bypass was very low, 3%. Procedural stroke was 0%. Total procedure time, 2 hours. That's start to finish, but the actual kind of device time, we actually have the device in 45 minutes. So I do think the record, I think was 17 minutes for the trial for device time. These are some of the other outcomes. You can see bleeding was still a major problem. That's a major problem with this population, not only because of the transapical access, but because of the fact that we're anticoagulating the patients immediately post-procedure. But most of these are pretty good for a first-in-class device. And we can see that the retensioning thrombosis endocarditis within the first year, pretty low, single digits, less than 5%. So the trial met its study endpoint, freedom from mortality or heart failure hospitalization, 60% at a year. These are sicker patients. This exceeded the performance goal of 43%, which was set by the FDA. Based on control groups from COAPT and heart failure and MAC populations. And you can see the 1-year mortality was about 21%, 20%, freedom from mortality 79%. And you see the heart failure hospitalization was about 30% at a year. But importantly, these patients, have an initial insult with the, transapical procedure, but in my experience and what we've seen in the trials, that once they get through that, I guess like a lot of cardiac surgery, there's an initial period where patients feel worse, but then because they have complete elimination of MR, then they feel much better. So the average KCCQ improvement was about 19 points, which is pretty high. Looking at the MR reduction, it was as expected, almost complete elimination of MR, which is really what you'd want. Mitral gradient also at 12 months, only 3.8. So these patients didn't have a lot of structural valve deterioration or development of mitral stenosis. So here's the paper, which was published in September 2025. It's still in a pre-proof format. If you go look it up, it's not yet in the beautiful Jack format, but it's in this format, and I'll stop there and open for discussion.
Thank you very much, Jason. That was a great presentation. Any comments from our surgeons, Ben and Yoshi?
I'll comment a couple of things. If you look at the bleeding issues, the apex ended up being less of an issue as we've kind of learned to deal with the apex. Like anything else, there's surgical tricks to it. For those people who still kind of cringe at the thought of apical access, particularly with the experience of transcatheter aortic valve data, we've kind of learned from that. And what's slightly different about this system is, as Jason showed you, there's a pad at the end when we put this and tether the valve. And that pad is essentially like putting your thumb on the end of a wound, and it does a lot to control it. Whereas when we're doing transapical TAVRs, the closure with your pledgets has to be hemostatic, and that's what closes it. So the tendency at that time is to kind of tie it really tight with the idea that that's your hemostasis, period, end. When we are doing this, we put purse strings that are a little bit larger, and then when we snare it down, we don't really kind of snare it down to kill it. It's really, when we surgeons talk about it, it's this to that, tying down. So it's gentle with the idea that even if it has a little bit of a leak at the end, that you're putting your thumb on it with this pad at the end. And there are also some other tricks as we go around and teach the approach to minimize the trauma at the apex. We are putting a very, very large cannula through the apex, and as the process of kind of dilating and then eventually putting the delivery system in, we're going from smaller to larger, and generally it's hemostatic. That being said, as we are manipulating this delivery system to deliver the valve, there can be some leak around the apex. Now we have purse strings to control this, but early on we used to kind of snare the purse string down with the intent of, yes, that controls it. The problem is that's not the best way to control the apex, because now you're tightening your purse string on it. You're still manipulating, and you have the potential to start to create some damage at your purse string site. So now, as we are instructing our teams to do this, we basically can just control it with a gentle tamponade with 4x8s. And then when we remove the delivery system, you basically snare it once with the idea that we're minimizing the kind of extra trauma. So there are a lot of tricks that we do to kind of minimize this. And I think that over time, hopefully that'll even go away. One of the other things, if you looked at the data, there were some, we had one of our patients, unfortunately, when we were doing the balloon dilatation, we actually used a relatively stiff wire to do it. And it was a post-op x-ray which showed that he had a right hemothorax. And it was just that we had used the stiff wire, and we kind of were maybe a little enthusiastic, and it went into the right side. And so we had to put wash him out from the right side, even though obviously the access was from the left side. So yeah, like anything else, early experiences, we learned a lot of things, and God willing, we'll get better at it.
Yeah, I mean, I think just the transapical, right, is kind of people are not excited about that. I mean, honestly, nobody's that excited about it, but it does have certain advantages to the predictability of access to the valve. It's very, you're not making any curves, you're not having to deliver any. I mean, it's just right there. And you've taught us, Ben. You've been to our center. You've showed us your tricks. I mean, these are very important. But the ability to retrieve it completely and reposition it is still a big deal. I still I mean, I still worry like a lot of TMVRs. I mean, great. If it goes in great, that's great. But I mean, if it doesn't, I'm always wondering like, hey, what do we do once we deploy a lot of these transfemoral valves that can't be repositioned? It'll get better, but it is kind of nice with transapical. You have complete control.
Hey
Right.
Jason, I think the whole premise of all these transcatheter mitral valves for MAC is sort of the patient that you showed, right? I mean, 85, I mean, 15,000 cubic millimeters of MAC. I mean, no surgeon wants to touch those cases, right? And we're seeing more and more of these MAC cases, and I think this is where the value is. So, question to you, Jason, do you think that that neo LVOT of 250, now that 10 is going to get commercialized. How low do you think Abbott's going to go down to?
Yeah, I mean, Mayra is. Yeah, I'd like her to comment too. I think for the 10-9 prosthesis course, it's a pivotal trial. We want to be very conservative. I think we can go down. One of the analyses we're looking at is that will come in the future is what was the predicted, and then what was the actual that we got in follow up,
Yeah.
and probably it's going to be a little bigger than we think. It also depends if patient has some degree of mitral stenosis because LV is underfilled. So maybe in those patients, we can be a little more aggressive because we expect the LV to get bigger, after we relieve the mitral stenosis. So there's some nuance we have yet to learn, but I think, getting closer to 200 is going to be good. Now, in the trial, we weren't allowed to do any leaflet modification intraprocedurally. A couple patients did have alcohol septal ablation, and then were resubmitted after that, but it was not allowed, concomitant.
And the
Mayra, what do you think about the neo LVOT number of 250 in this trial?
I agree that that's a little conservative, but that's what was needed to get the outcomes that you got. I think we need to congratulate the surgeons and thank Dr. Sung also because he came to our center to teach us. I think we need to congratulate the surgeons. I was concerned about transapical access, particularly in this patient population. This is real MAC. You saw the amount of calcium. And just by the presence of MAC, it tells you all the comorbidities that these patients have. So I was concerned, but I was pleasantly surprised. First, if you go back to the early experience with Tendyne, it was like the first transcatheter valve and showed a 30-day mortality lower than predicted by the STO score. And then you take that early experience on the global EFS of the 100 patients and extrapolate that into a much sicker population, which is MAC. And despite that, the outcomes, at least the acute outcomes are favorable. Long term, we know that these patients die, and I don't know that is the valve procedure that accelerated the death of some of those patients. Maybe those patients were going to die no matter what, but the survivors had significant experience of symptoms. So I think that the outcomes are as good as probably as we can get in early experience in MAC. And now it's going to be yet to be defined how far can we push the envelope now in the commercial world. I think having CT before and after, or looking at the hemodynamics, many of these patients had a pigtail catheter, right? Like before and after, and understand what was the hemodynamic change, like we did in the early experience of valve, green valve, MAC, to try to understand at what point does your gradient in the LVOT start to increase. That's when we came up with a cutoff of 189.5 or something like that, 189. So it was close to 190. We just said 200. But we had the hemodynamic data. So maybe now we can look into that. Or in the commercial world, try to get the CT before and after, like you said, to understand what is the predicted and the actual neo LVOT. So I'm sorry, I gave you a long answer and did not really answer the question.
No,
Well,
much
if I
more.
can add one more thing, the other thing that we still need to pay attention to is the length of the anterior leaflet of the mitral valve, because we still, even if the volume is okay, just by this pushing it down, you can windsock it because the low profile valves, which is what we typically use right now, have a short skirt. And so if the leaflets are really long, it can still hang below the skirt and hence catch the LVOT and create systolic anterior motion. So that's still something TBD, how much we can tolerate for the anterior leaflet length.
We can fix that. That's easy to fix. There's a solution for that. And also, I mean, if we have a borderline, neo LVOT, we can modify the septum, before or during. Ideally, I would think that before, because we don't want to be in the situation where you have acute hemodynamic compromise from obstruction. I see.
Yes, well, we'll get the slides up, but Gennaro, please comment. Kelly, can you put the slide
I
up?
actually I've never done a tendine, so actually I have a question.
Yes.
Now that the tendine is going to be adopted in the real world, how much you think leaflet modification during tendine is going to be implemented? Because I saw like recently was published in Air Intervention this registry implemented a mitral cut technique where I believe in Germany through the transapical axis with endoscopic scissors they will cut the anterior mitral leaflet first, followed by tendine implantation. That seems like a very good, like straightforward strategy for these cases. Do you think like this is going to be like implemented routinely or like more frequently?
Well, there's more lawyers per capita in the United States, so
That's a good.
but I mean, yeah. Yeah, I mean, I think the answer is yes, we will be doing that. But I'm pretty sure the sponsor is going to be very conservative in the initial rollout. They're not going to want a lot of sites doing that type of thing right off the bat. But no, I think that's where we're headed for sure.
Maybe I shouldn't say this, but there was a case in England where early on there was a systolic anterior motion, and they put a pumice stent on there so that it just tacked to the leaflet back, and that patient is still 8+ years out now, and still doing well. So yes, the septal ablation is probably the first way to go if it really is a volume issue and high up, and you have access to a good septal. But if it's a SAM, then there are going to be other things, and you guys are going to figure out all kinds of interesting ways.
So I have to stop this because we get to the next case because of lack of time. So I love this discussion, but Attizzani, you're up next because we will continue because now we're presenting the transfemoral, transcatheter mitral valve repair, the Alta valve. So Guy.
Thank you,
The floor is yours.
Nadira.
And we'll get the conversation going some more because it's so much more exciting.
So thank you so much for the opportunity to present this case, this Alta valve case. And full disclosure here, before I go over the details of this valve, the first time I saw the prototype of this valve, I thought to myself, this cannot be easy to implant. This should be a very cumbersome system with all this cage in the left atrium. I was very positively surprised on how easy this device is to implant. Next slide, please. So this is a case that we had screened. Obviously, the patient failed the potential for MitraClip as well as for Apollo trial. And we were left with the option of including this patient to treat with the Alta valve. So as we know, a lot of patients that we screen for the clinical trials, we've been very frustrated, for example, with Apollo, that we have a long list of patients that end up being excluded for potential for LVOT obstruction. And that's where this valve potentially can help and avoid these cases, right? Adjunctive procedures, we talk about Lampoon and others, we end up having to do these procedures as well as all septal ablation. So that is certainly a concern, the LVOT overall. Of course, also the annular size limitations that these devices have and the interference with native annular dynamics. And the anchoring mechanisms such as barbs, hooks, and pedals, they might be difficult for patients with MAC. And obviously, PVL is always a concern. Next slide, please. So the Alta valve, the cage conforms very well with MAC. And the deformations on the outer frame, as you can see here, there's an outer frame and the valve is housed on this inner frame. And therefore, those deformations, they do not affect the valve function. and it has a TAVR-like deployment in MAC, right? So there is minimal interaction with the LVOT, which preserve the structure and reduce the potential risk of obstruction on the LVOT. And in fact, in the screening process, it does not even include the neo LVOT assessment. So that's a very, very different from the other devices that we had available until this point. Next, please. So it's a very flexible annular ring that moves away from the LVOT in systole, and therefore this risk, as you can see on this CT, on all the cardiac cycle phases here, the risk of LVOT obstruction is consistently minimized. Next. So this is our patient, 83-year-old patient, functional class 3, high risk overall, other diseases, GERD, worsening RVR, atrial fibrillation, obviously a substantial murmur, and increased fatigue. She was really having a miserable quality of life. As I said, she was not a candidate for surgery, not a candidate for TEER, and she failed the screening for the Apollo trial, and therefore we remained with this option. Of course, we would consider potentially also for mitral valve MAC, which she also failed, and therefore we had the option of the aorta valve. Next. This is her echo. As you can see, a degenerative mitral valve regurgitation with a partial flail, and she has a severe MAC, which we're going to see in the CT next. Normal ejection fraction. Next. So severe MR, as you can see. Next. You can go to the next, please. So here is the valve, and I want to emphasize one aspect is that the fixation mechanism of the aorta valve. You can see the cage that you see that is basically on the left atrium. Both the height and the width of the left atrium are important on the fixation mechanism, and the width is the main mechanism of fixation. So basically what happens in the screening process, not only the initial screening obviously happens with the echo, and then the CT, they perform those measurements, and the valve, the actual cage, is actually customized per each patient, and the valve is the one, as I said, protected from the potential interactions with the MAC. Next. Here you can see the MAC, so 202 degree of MAC, not as calcified as the ones that we saw in the prior slide that Jason showed, but the volume of MAC also substantial, which was considered as severe MAC, as you can see here on the 3D on the on-FOSS view. Next. So this is basically the steps of the procedure, to starting with the balloon septostomy on the left, then access to the left atrium, and the deployment of the valve, which is different. When we do, for example, the Apollo valve, we really strive to have a very coaxial position, whereas with the aorta valve, when you're implanting the device, you basically anchor the device on the lateral commissure. And another important aspect of the device is that it's fully recapturable, right? So the fact that in case we actually had one case in the past that the valve ended up migrated to the atrium, and we could fully recapture the device and reposition and then redeploy. So that delivers substantial amount of safety to the procedure, right? And it is a very, very stable deployment without the need for rapid pacing. Also important to mention that, right? So basically, the distal part, you see there are two connectors, one in the inflow of the valve, as well as one on the top of the cage. So the one in the bottom is released first. Then there is a snare that goes around the valve that is released after that. And although the visual aspect of the valve seems cumbersome, it's a very easy process of deployment. And finally, the final release is the one, the final release is the one on the top of the cage in the left atrium. That is the final release of the valve. Next. So this is the echo pre-implant and the post-implant on the right-hand side. Of the patient recovered and she was NYJ functional class 1 with non or the trace mitral valve regurgitation, very minimum MR. The ejection fraction was maintained. Next. So these are the follow-up echoes. So she reported really substantial improvement, this patient, and she's been really doing very well. I saw her relatively recently, and she's really doing great. There's no LVOT gradient as predicted by the mechanism of anchoring that I mentioned to you. Next. So in summary, then high-risk MAC patient, she was not a candidate for any of the devices that we had available, MitraClip, mitral valve in MAC, or the Apollo trial. MR reduction improved clinical outcome, which was sustained over 1 year follow-up, and the Atlas pivotal trial is enrolling with a dedicated MAC cohort. And once again, this is a very stable deployment in a device which is fully recapturable, which ultimately delivers a very safety to the procedure, and I think the peace of mind to operators overall. Thank you very much.
Thank you, Guy. And Yoshi, you're the PI, the US PI for this trial. Any comments, and then Mayra and Ben as well, your thoughts about this device who, they are currently enrolling in the MAC cohort. What are your thoughts, versus the Tendyne?
I mean, Guy explained it really, really well, but what really stands out, it's its uniqueness of how to fix that valve. It's different from Tendyne for sure. Tendyne's fixating it to the annulus in the apex, right? But this one's really fixing it in the atrium. And I think that uniqueness brings some of the benefits. Guy already mentioned that we don't screen for LVOT area for these cases. And I think that's a huge, huge benefit because that is one of the major exclusion criteria for these transcatheter mitral replacement trials. It does have some unique aspect in the management as well. There were patients that cardiologists measured BNP and they were exponentially elevated. That's because the atrium stretched. So BNP really rises without any heart failure symptoms. And, Guy showed that we do measure the left atrial volume change. That is one thing that we pay attention to. If there's a lot of volume change, then we do get concerned whether the valve stabilizes. But we have been increasing that threshold. So hopefully it won't be that much of a problem in the future. So the uniqueness is always good.
Yoshi, I have one question. So as you know, today they're kind of customizing per CT, right?
Yeah.
To make this product commercial, right? What is the plan, right? In terms of what's going to be now once the device is approved, hopefully it's going to be, right? What is the plan to make this commercial? Because, customizing for every patient is going to be trouble.
I'm telling you. So, I was wondering the same thing. And when I talked to the company, a lot of the atrial size goes down to like 4 different sizes that are most commonly utilized. So it's almost like a suit out of the rack. You don't need to get tailor suits every single time. So I think you're going to get like 4 real commonly used sizes. And then some of the other custom ones, they'll make it for you. That would be my prediction.
Mayra.
Hi, thanks. A question about screen failure rate, because my impression was that precisely because these are customizable, that basically everyone could be included. And I must say that I've been trying to get patients enrolled, and most of them, they screen fail despite this being just a atrial fixation mechanism. So can you tell us about the main reasons for screen failure rate? What's the rate actually of screen failure? And
the anatomical screen failure rate, Mayra, is somewhere between 30 to 40%. And as I mentioned, the left atrial volume change was one of the common reasons. And the other one is the atrial size. If the left atrium's too big, then that's another reason not to perform. For the MAC trials, contrary to, what Jason presented for Summit MAC, in the beginning, we were only enrolling MR patients, severe MR patients with MAC. Now we're doing moderate MS patients. We haven't done MS only at this point. So there are some slight differences.
MR combined? I'm sorry.
Yeah. That is correct. Moderate.
Just like the other trials.
That's correct. Yeah.
I think one of my patients got excluded due to high risk of LVOT obstruction. That's not the case. It's never the case, you said, or there are some cases.
Yeah, we don't typically screen for that in, as sort of the typical criteria, but I do know that Joel Cavalcante over at Minneapolis Heart, he does screen some of the CT patients that is going to be considered high risk. So I do know that there's some screening that occurs in specific patients.
One of the attendees asked a very interesting question. How about ASD closure in these patients? And I know Yoshi has a huge topic with this valve and re-accessing this through the, if you close it, re-accessing it into the atrium. I know I've had experience with it.
Yeah,
it's possible. It is possible. We have done it. So, Yoshi, do you want to comment on that?
No, I think, we actually encourage to close the ASD because it does change the flow quite significantly after the valve deployment. So if that ASD persists, there is a continuous left to right shunt that may increase that flow into the right-sided system that may mitigate some of the recovery. So I think for a lot of patients, we do encourage closing the ASD at the time of. And I think the concern is always going back in, but you guys have some devices that allows you to go back in, right? So
yes,
I'm going to make a comment. I just for full disclosure, I'm on the DSMB and CEC for this clinical trial. So I will limit one comment and say, if you close the ASD at the time of procedure, it is not an AE. If you come back in, then I have to review it.
And just one quick comment about the closing the ASD. We have a N of 2 cases, obviously, but we closed both cases, and it's technically very easy. That there was no issues with interaction with the cage. It was very, very smooth to do it.
Use Amplatzer or Gore?
Amplatzer. Actually, we used one Platzer in one and Gore in the other one.
Yeah.
Does the frame get trapped between the disc and okay, because so it's you're actually closing on the frame. Gotcha.
Yes. So interesting discussion, but the last but not least, due to time, really exciting to hear from Dr. Gennaro Giustino on another interesting case on bags. So Dr. Giustino, floor is yours.
Yes, so my presentation is more about a technique coming from very off-label use in patients that are not candidate for good things like dedicated TMVR devices. So as we have seen, severe calcific mitral stenosis is common, is therapeutically challenging. Very often these patients are not surgical candidates, and very often TMVR is contraindicated when the mitral annulus has in an incompatible sizing, or where, for example, valve in MAC due to insufficient mitral annular calcifications. A few years ago, IVL has been used to facilitate percutaneous valvuloplasty in patients with severe calcific MS. I'm going to go over some of that data. And at that time, the original description included the use of shockwave balloons that were smaller, since the bigger balloons were not available at that time, that do not fill the entire mitral valve annulus, then followed by a conventional valvuloplasty balloon inside of the MAC with severe mitral stenosis. This was the first report. It was in 2019, done by Marvin Ang and Bill O'Neill at Henry Ford. At that time, so those were like 8 millimeters balloon placed in parallel inside of the MAC, followed by a valvuloplasty balloon. When I was at Henry Ford, we continued to perform such procedures. This is the largest series reported. It was published in JACC Intervention. These were 24 patients with severe MAC and mitral stenosis that were not suitable for dedicated TMVR, that were not suitable for valve in MAC and or TEER and had IVL-assisted mitral valvuloplasty. You can see here, most of the patients were treated with like a combination of 2 or 3 balloons, followed by a valvuloplasty balloons. We were able to show that most of the patients had a reduction in gradients, an absolute difference of about like 5 millimeters of mercury, and 90% of patients had the residual mitral gain less than 10. So now, since I left Henry Ford, now I have in Morristown in New Jersey, and the shockwave, the shockwave peripheral balloon that they're big up to 12 millimeters are available. We have modified the technique such as that the entire shockwave balloon can fill the mitral annulus based on some characteristic on the CT sizing. And the rationale of doing that was actually to remove then the valvuloplasty balloon after the shockwave to make the procedure safer and see if it was like similarly effective. So we published this variation of the technique in structural heart earlier this year. This was a very small series, only 7 patients done between Morristown, Henry Ford, and Beaumont. Where essentially I'm gonna go over how did we do this, but essentially these were all patients where TMVR was contraindicated due to prohibitive risk of LVOT obstruction. There was insufficient annular calcification for valve anchoring, and they were all at prohibitive surgical risk. The usual characteristic of a severe MAC population, actually most were female. There was only 1 male. Average age was around 80. They were all prohibitive risk patients. Peak gradient around 25, mean around 9. This was from the interprocedural T to start, and most of the patients had essentially no MR. These are steps of the technique that we have modified. So essentially, after transeptal access, we will use a Pascal sheath, which is 22 French, goes transeptal and steer down towards the valve, cross the valve with a pigtail, and then send 3 014 or 18 wires, and then over this sending the shockwave balloon. So these are positioned inside of the mitral valve, and then go up on the balloon and then deliver the shocks, and then go down and up again until like satisfactory results will be achieved. During the case, you could retract the balloon inside of the transeptal sheath to see what is happening to the mitral valve, if the gradients are being reduced or if mobility is being restored. These are like some fluoro images of what this looks like. You can see the 3 balloons, one next to each other, inflated inside of the MAC, achieving like annular contact. This is what on transesophageal looks like. Again, the rationale here was again to try to achieve contact with the structure, with the calcified structure of the valve. Most of the patients here were treated with at least 3 balloons, and most of the patients were treated with a 12 millimeters balloon. Again, consistent with the rationale. We use embolic protection in most of the cases. There were no strokes in this series. And in terms of reduction, we were able to reduce from mean gradient about 9 to 3, peak gradient from 25 to 9, and without increasing mitral regurgitation. These are the individual results per patients. Not obviously as impressive results as a TMVR platform, but nevertheless significant reduction in gradient. And most importantly, there were no interprocedural complications. And 30 days follow-up, 50% of the patient remain with gradient less than 5. We don't have longer-term follow-up. We're going to be collecting that. I'm going to show some case examples. And the first case I'm going to show is actually a case where I wasn't able to achieve a very impressive result, but I just want to go over how the discussion happens with these patients. So these are an ETC, a very, very pleasant 86-year-old female with multiple comorbidities. She is an NHA class 2 and severe mitral stenosis. Her symptoms really is that when she walks around the house, she gets short of breath, and then she gets frustrated because she cannot do as much activity as she would like to do. CT shows severe MAC, septal hypertrophy, prohibited risk of obstruction with S329, including with lampoon that will require also septal modification. Screen fail for TMVR trials. I was trying to walk her through what it would be to do a valve in MAC with an alcohol septal ablation preemptively and a lampoon, and there was no way I would be able to convince her to do so. And most important, she didn't want to have an alcohol septal ablation because she didn't want to have a pacemaker. So at this point, what to do? So I offer the balloon procedure. Listen, at the very least, if this works, you can feel a little bit better. If it doesn't work, this is safe. There's a low rate of adverse events, and you'll be able to go home the next day. And she signed up for it. So these are the CTs. You can see usual MAC, very thick ventricle, very tight LVOT, would have required septal ablation and lampoon. This is with the lampoon simulation. So end up a skirt knee LVOT or about 158, and the knee LVOT essentially 0. So I wasn't offering a valve in MAC with lampoon without doing an alcohol septal ablation, and she was refusing alcohol septal ablation at every single cost. These are the baseline images. You can see very tight, calcified, dense MAC. This was some images from the procedures. And very importantly, also the rationale of not doing an aggressive valvuloplasty after this is because these patients are non-surgical. So if for whatever reason, I cause severe MR, which obviously we'll be afraid of, then this patient would have no options. And didn't cause an increase in MR. And there was a modest reduction in the gradient. This was under general anesthesia and transesophageal, pre and post from 7 to 4. And these are the areas, went from 1.4 to about 1.7. This is another case, much more dramatic. This is another woman who had a TAVR 6-7 years ago, and now she presenting recurrent heart failure with very tight valves, the area is in the 0.7. You can see in the general anesthesia mean gradient of 10, and on transthoracic her mean gradient was close to 20. This woman was treated with only 2 balloons. You can see a waist on the shockwave here. And then after, there was no increasing in MR, and the gradient was reduced by half, and the air increased. These just to show, this technique has been now implemented at other centers that were completely unrelated to us. This was done at Newark Beth Israel. This is case courtesy of Dr. Vucic. So this is another patient, 79-year-old female with same exact stories, severe calcific MS, can't do TMVR, can't do valve in MAC, and all of that. This is the CT. This is baseline TE. Again, very, very small and thick valve. Mean gradient of 10. The operators used the exact same technique using the same strategy for the sizing, and they were able to reduce the gradient by half without increasing the MR. You can see some increase in pliability as you're doing this. While you're going with the balloons up and down, you will see that the valve is gonna start moving more. These have been other techniques that have been reported out there. One particularly very nice case done by Dr. Tayal, where the patient was actually in shock, and was able to increase the air from 0.7 to 1.7 with the technique. And this has been done also like in Europe, in France, in Italy, using variations of the technique. And that's it. Thanks.
Thank you so much, Gennaro. That was so impressive. Any comments and feedback? I know there's a question from Nick online, but yes, Yoshi, then Mayra, please.
No, I've got two questions. So this is fantastic. Because if I've seen Macs crack and they can die from that. So I think not using a non-compliant balloon is great. How's the hemodynamics when you blow these 3 balloons? Are they stable?
Yeah, that's a great question. So the balloons are partially occlusive, so the blood pressure will go down, but the patient recovers right away. So what I will usually do, like I let the patient breathe, come back with like normal baseline hemodynamics, and then start again. And you can keep doing this. It's very I've seen, I think I've done it now a number of times, but I can confidently say that it's safe. I haven't had any patient crashing during this type of cases. Even that case that I show with the valve was like so tight, they come back right away.
Mayra?
I just want to confess that I saw a question from Nick Amoroso, and I
That's right.
replied, and it disappeared. I just want to mention his question because I no longer see it there. He was asking, how do we know if the benefit is from the lithotripsy energy, or if you were going to see the same benefit with just the balloon valvuloplasty that you do after? And I replied to him saying that that's my question too. Without a head-to-head comparison, it's hard to know, for me, to understand the incremental value of lithotripsy. We've been doing valvuloplasty, for a long time. That's how the idea came up. That's how we came up with the idea of doing TMVR, because we know that the benefit doesn't last that long, or at least not without the lithotripsy that when we were using regular balloons back in 2013. And when we do valvuloplasty, we have impressive results acutely. And I must say also, I don't think I've seen significant increase in MR. But the question is, they do reach the nose. So I wonder, how the speed at which they reach the nose after lithotripsy, or any head-to-head comparisons, or plan for any head-to-head comparison, regular valvuloplasty versus lithotripsy-assisted valvuloplasty.
Gennaro, before you answer Mayra, my question is related to hers. Have you done CT post to show the fracture of calcium? Because that's related. I was having the same thought of Mayra now. So have you done that to confirm that you indeed fractured calcium?
Yeah, okay. I'll answer to all the questions in block. So Mayra, first to this variation of the technique did not include a valvuloplasty after the lithotripsy. I just did the lithotripsy. In a way, with the bigger balloons such as that, the balloon will occupy the entire space. So probably there is, to your point, a component of the effect maybe is related to the lithotripsy. Even these balloons are not really designed to penetrate such thick calcium. And an effect is related to the actual fact that you're inflating a balloon inside of the valve. Now, lithotripsy balloons are not like non-compliant valvuloplasty balloons, so they are more gentle. And what it makes me comfortable about this technique is just that being gentle, like you're actually reducing the risk of damaging the valve. But that being said, this technology is not designed to do this. So we wait for dedicated platform that can actually address calcium in valves. So to the CT question, I've done it. You can't see anything because I don't have enough spatial resolution with the CT. That being said, there is a cadaver, very interesting cadaver study that was presented by Jafar that showed that the current balloons actually induce using micro CT. They actually induce fracture in the MAC. Now, I have been doing this in like different type of morphologies in the valve. In my anecdotal experience, the one that responds the most are not the ones that have very thick annular calcium encroaching the valve, are the ones that have like less calcium in the annulus with like probably like those kind of MACs that have like high embolization risk, and more calcium extending to the commissures and the leaflet. And when you do this, you really see that the leaflets start like being like more mobile. So I think we are all learning who responds to what, but like in my experience, at least, those are the ones that get the more benefits. I don't know if it really is important to characterize how thick and dense the calcium is outside.
Yeah, one quick comment. I mean, I think we all want this to believe this works, but we definitely need a control arm, and it's just almost too good to believe. And some of the cases I've seen when they've presented the gradients, like before the heart rate was 90, and then the follow-up echo, the heart rate was 60, and they're like, oh, the gradient got better. It's like, well, they got a beta blocker. But I mean, just the cost of this, if you just start adding up the Pascal sheet, the 3 balloons, the 3 generators, embolic protection device, I can't even, I mean, it's, I don't know that most centers can afford even to do this, right? Because none of it's reimbursed.
No, it's cost is an issue. I mean, these obviously are patients that have no other options otherwise, but costing is an issue. You can do this without the Pascal sheath. Something else that you can do is to occupy I've done this. You can fill the valve. Instead of putting 3 shockwaves, you can put like another Armada balloon, so just like at least like shifts the shockwave balloons towards the commissure, where probably there may be most of the effect. But I agree with you. Like, I mean, all of this like experimental and cost, yes, is an issue. So many centers can't really afford to do this.
Ben, you have the question? Oh, you're muted.
I'm still muted. Sorry. So the energy is different, obviously, because you're using lithotripsy. Surgeons had used these cavitron ultrasounds in the past to try to decalcify aortic valves, and we can get good early results with nice pliable leaflets. But they all developed valvular insufficiency as the tissue kind of retracted over time. So something to see. Is there any series or any of these patients are out more than 8 months or a year, and see if there's any retraction in any of these leaflets?
So in the small series that I follow up at 6 months to 1 year, and I've not seen that. In the series from Henry Ford, where we've been doing this for more years, we are working on the longer term follow up. But those patients were treated with a valvuloplasty, so it's a different concept. So yeah, we'll need to see long term follow up.
With that, I mean, we're at top of the hour. Thank you so much to all the presenters. Well done. Thank you. And my moderators, I couldn't have done it without all of you. And this is the last 2025 Nail It with Nadira webinar, and we'll be back in the new year with 2026. So have a great holiday with your loved ones and family, and we'll see you in 2026. With that, thank you very much.